I am Diatitya in third year B Physiotherapy from Marwadi University. Today my topic is medical management of pneumonia in general medicine. So let's start it. First of all, we are understanding what is pneumonia. Pathological consolidation. According to clinical guidelines, pneumonia is defined as an acute infection and inflammatory of the lung parenchyma where alveoli fill with inflammatory fluid. In pneumonia, the alveoli are filled with inflammatory fluid and air loss in lungs. Exudation. Fluid with white blood cells, cellular debris fill the alveoli. Consolidation. The normally spongy lungs tissue becomes solid and airless, severely impairing vital gas exchange. Gas exchange are impaired. Then key symptoms of pneumonia: sudden onset of high fever, productive cough and sputums. There are key symptoms of pneumonia. So we are understanding clinical classification of pneumonia. Clinical protocols categorize pneumonia based on both anatomical distribution and the setting where the infection was acquired. First type of pneumonia is lobar pneumonia. It involves the large continuous portion or entire single lobe of lung. Then we are understanding second type of pneumonia, bronchopneumonia. Patchy distribution centered around inflamed bronchioles of bilaterally. Then community acquired pneumonia and hospital acquired pneumonia. Separate some. Then we are understanding diagnostic methods of pneumonia. Gold standard assessment we are understanding. Before initiating empiric broad spectrum therapy, specific fundamental diagnostic procedure must be prioritized to pinpoint the clinical etiology. First of all, we are taking the chest radiography, sputum studies and complete blood count. In the chest radiography, essential to confirm consolidation, pleural fluid or cavitation. Use of sputum studies, gram stain and culture and sensitivity of identify organs like pneumococcus. Then complete blood count is useful for shows marked leukocytes, high WBC counts with a classic left shift. Then we are understanding essential supportive care of pneumotic patient. Basic clinical foundation. Supportive care is just as critical as antibiotic therapy. Clinical guidelines advise immediate interpretation of general stabilization steps like bed rest and hydration. In bed rest and hydration, absolute bed rest and IV fluids to thin out tenacious bronchial secretion. Then oxygen therapy. Oxygen therapy is administered via mask or nasal cannula. Oxygen saturation SpO2 falls below 92%. Then symptoms relief. Then we are understanding managing community of pneumonia, targeted outpatient and ward cap. Empirical antimicrobial therapy must be initiated immediately without waiting for culture results. Tolerated carefully by CURB 65 severity. Then mild outpatients, oral amoxicillin. Moderate outpatient, IV certificates. Duration typically 5 to 7 days for incompletion bacterial CAP cases. Then handling hospital pneumonia is severe pathogen cover. Hospital acquired pneumonia demands highly aggressive therapy to combat virulent drug resistant hospital strains. Pseudomonas coverage atypical or gram negative. Then MRSA suspected. In Pseudomonas coverage, anti-Pseudomonas beta-lactamase such as piperacillin, tazobactam. Atypical gram negative in levofloxacin or amikacin can be combined for synergic effect. Then MRSA suspected add linezolid or vancomycin immediately to the IV regimen. Then we are understanding managing atypical cases, cell wall deficient organisms. Pathogenesis like Mycoplasma pneumoniae or others are typical cell wall and will not respond to beta-lactam antibiotics. First choice ultimate drugs and first choice drug is macrolide, then alternative drugs is tetracycline, represent an excellent and cost-effective second option. Then monitoring and evaluation, tracking patient improvements. Standard protocols note that clinical improvement is seen much faster than radiological clearing. We must monitor parameters symmetrically. 48 to 72 hours expected timeline for temperature drop, heart rate deceleration and breathing case. Then we are understanding preventing complication of pneumonia. Complications to avoid. Untreated or delayed treatment can lead to severe systemic or pulmonary complications as highlighted in clinical life struggle. Pleural effusion, accumulation of sterile fluid or gross pus in the pleural cavity requiring chest tube. Then lung abscess, cavity destruction of lung tissue commonly caused by aspiration of oral anaerobes. Sepsis and bacteremia, spread of infection to blood causing septic shock. I will try better to understanding the lecture for you. Thank you.